Mo, the doctor is in.
Hey, happy Hump Day Wellness Wednesday. The doctor is, in fact, in, and we are so excited to have everybody here tonight because we have to talk about something that a lot of people think they know a little bit about, but not enough about, not enough truth about the topic of lymphedema. So, Ricky, did you know what lymphedema was when you first got diagnosed with breast cancer?
No idea.
Right.
No idea. No idea. No, I never knew what it was until I started being around breasties who had sleeves on.
And you wonder what those sleeves are. I remember watching my grandmother who had breast cancer not once but twice and had lymph nodes removed on both sides. And I didn't understand as a little girl why she would complain about swelling in her arms and pain underneath her arms from her incisions and from fluid buildup in her fingers. And so we're going to talk about lymphedema today, and we're going to let our panelists really take over. But before we do, I just want to define what lymphedema is. So lymphedema can either be what we call primary or secondary, and the lymphatics, let's start there. Lymphatics, I like my easy to understand analogies. It's like the spider web system underneath the skin that moves the fluid around. That's not blood, that's not saliva, that's not urine. So all the other fluid that clears infections and inflammation, that helps to carry those white blood cells that help our immune response, all travel through the lymphatics. And if you think about underneath your skin, there's a thin little lattice network that's all connected throughout the body like a spider web. That is your lymphatic system. It is responsible for clearing out infection and inflammation. And so when there's an injury or a damage, or the easiest way to think about it is if you mess with the pipe, if you mess with the plumbing, you can get back up in the pipes. And so breast cancer surgery looks to examine the lymph nodes, because we know that breast cancer, if it is going to leave the breast, will travel through that spiderweb system, through the lymphatics into the lymph nodes, either in the armpit or in the chest. And then from there, it can go anywhere through the body. So after a patient gets diagnosed with breast cancer, the next question they ask is, well, how do I know it's no place else? How do I know? And so by checking the lymph nodes and doing a surgery to remove them, that's the way that we can find out if cancer has left the breast and gone into the lymphatics and then traveled potentially throughout the rest of the body. So, that being said, we got anywhere from maybe 10 to 30 lymph nodes underneath the arm. Most times the surgery just takes out one or two, but if there are more that are involved, we can take out 5, 10, 20, sometimes even more than that. So lymphedema can be a really big problem because this is the primary drainage system under the arm for the breast and for the arm.
Wow, I had 10 taken out and 7 had cancer in them. But I never got lymphedema, and I don't really know why. I mean, I was blessed, but we have 2 awesome breasties here today, and I'm going to let them introduce themselves and to talk about their experiences and to talk about some things we need to know, that breasties need to know, that we are obviously not being told by our doctors, and our medical professionals. So Robbie, welcome. So glad you're here.
Thank you so much. So my name is Robbie Cooper, and I'm a patient advocate. I am a 13-year breast cancer survivor. I was diagnosed December 2008. My breast cancer is estrogen positive, and it was stage 3-4. They couldn't really determine if it was 3 or 4, so it's somewhere in between there. So that's who I am.
Great. And Dr. Cherie, remember Dr. Cherie from our walk?
Yeah. Yes, this big old face and this big old mouth. Yes, I'm Dr. Cherie Prentice. I too am a 13-year breast cancer survivor. I was diagnosed in October of 2008 with stage 2A invasive ductal carcinoma of the right breast. I underwent a partial mastectomy, 15 rounds of chemotherapy, and 33 treatments of radiation. Within a year, I did develop disabling lymphedema. And we'll talk more about my story, and we already have talked about my story, but I can tell you this: with my development of my lymphedema and my newfound career as a professional speaker, because my lymphedema disabled me from my clinical practice as a physician, I discovered thousands of women who had lymphedema, and many of them didn't know what they had. They were told that it was just some swelling. Those that did know what it was, again, they were just told it was just some swelling. And then the ones that knew that it was more than just swelling, many of them could not afford the compression garments that were necessary in order to treat the lymphedema. So I started the Live Today Foundation with three primary goals in mind. It's a nonprofit that's a 501c3, and we do three things. One, educate physicians on how to properly diagnose. And the reason why I say properly diagnose is because there's too many patients out there that are coming to me and stating that I was told that it was just some swelling. Now, maybe the physician just used those layman terms and felt that maybe the word lymphedema was too big, but we have to be careful in making it too plain, because if they're hearing lymphedema, then they need to search and educate themselves on lymphedema. They don't know how to search and educate themselves on some swelling. So we educate physicians on how to properly diagnose it. Also make them aware of the psychosocial impacts of lymphedema on a person's life. I, as a physician, I knew about lymphedema. I didn't think about the impact. I didn't think about the financial responsibility of buying 2 sets of garments every year. I didn't think about replacing a wardrobe because one arm was bigger than the other. I didn't think about how embarrassing it could be when you have a garment that is not dressed up or attractive and you're at a cocktail party and everybody else is getting past hors d'oeuvres and looking really cute, but you have this garment on that people are looking at, trying to figure out why it is you have it on. And so when you make physicians aware of that, then they can provide the resources necessary to that patient for them to deal with that. Sometimes they need to talk to a counselor. Sometimes they need to just understand that this is normal. This is a part of the disease process. You are not alone. But if physicians don't know or don't think about it, then they don't have those kind of conversations with their patients. And lastly, because minorities are predominantly impacted, you name a disease, almost, we at the top of the list. Lymphedema is no exception. We provide free compression garments to under-resourced cancer patients and survivors living with lymphedema so that they can get a good start, the best start possible after having been diagnosed with this disease, when one disease caused another, to at least help them on their initial lymphedema journey.
Wow, wow. Well, Mo, I pulled some numbers to see, but basically 70% of breast cancer patients who have had surgery, mastectomy, lymph node removal, which happens most of the time with breast surgery, right? And you can help me with that, Dr. Mo, and maybe radiation are basically going to get lymphedema. And because Black women have more advanced disease, more aggressive treatment, of course, it hits us harder, as you just said, Dr. Cherie, like everything does. But I found there was a study that was done, a qualitative study in 2019, where it was a small group of women, but they were saying stuff like, my doctor never told me about this. I didn't know anything about it. I had no idea that this was happening. When my doctor first saw it, he says, oh, it's just swelling. It's going to go away. Don't worry about it. He didn't tell me I was going to have this thing, right? Or my doctor spent no time with me, as we always hear. So I heard nothing about it. I couldn't even ask a question, right? So we have a lot of work to do. And I think there's maybe some news that you're going to share, Dr. Cherie, but we're finding out today that it's not even really new news. It's just it's kind of a new data about an old thing that could be helpful to people that we should know about. So I think, we need to educate people on this.
You're absolutely right, Ricky. And I don't know if it's because doctors are so engrossed in telling women about their stage and about what's going to happen and all these things that they maybe rely upon other practitioners, physical therapists, nurses, navigators, and things like that to talk about lymphedema. But I know that I talk about it with every single one of my patients. And we talk about what the risk factors are for lymphedema. One of the things we got to talk about today is how do we assess and how do we manage people with lymphedema? Because, lymphedema, the assessment for it is somewhat subjective. When I explain to patients why they're going to a lymphedema prevention appointment. So every single one of my patients that's having any lymph nodes removed gets referred to my lymphedema prevention program, where they will then get wrist and arm measurements. So they measure the wrists at the same point, the forearms, the upper arms, and they counsel the patients on what to expect. But even even within that, there's a lot of variability and subjectivity in how we assess for lymphedema. And patients can walk away feeling confused and overwhelmed and scared. And sometimes they come back and tell me, I was told I can never fly without a sleeve. I can't garden. I can't get my nails done. I can't do this. I can't get my cuticles clipped. I can't. And there's so much fear about this lymphedema when, as physicians, we are taught that the risks of lymphedema are relatively low. When a person's having a sentinel node, 1 or 2 lymph
Wow.
3 nodes, 2 to 4% risk. So why would they spend a lot of time talking about what they're taught is a low risk procedure, but we're not taught. What we're not taught is that lymphedema can happen within the breast itself. We're not taught how to monitor patients for the early signs of lymphedema. It's usually once it's happened and your fingers are numb and your rings are tight and all these things are going on and patients are like, what's happening to me? Then we say, oh, I guess we'll send you to that therapist for the lymphedema program and get you a sleeve and some, some lymphatic massage. But it's something that really should be on every doctor's radar, and it's something that should be taught to every patient in a way that's educating and empowering and not scary. You know what I mean, Dr. Cherie?
Oh my goodness. Okay, so I would say this. It would be wonderful if every cancer patient who was newly diagnosed could come to you. Because
Yes.
you get it, Dr. G, you get it. Because here's the deal. Okay,
We
so
know that about
right,
and I
Yes.
tell everybody, you gotta go to Dr. Mo. She's the only one to know.
Exactly. Because here's the deal. You are so right. When we're dealing with just sentinel node, the risk lowers significantly. But Dr. Mo, we're not fully there yet. And right now, we're still living with the fact that 1 in 3 at-risk cancer patients will develop lymphedema related to their cancer treatment. That's where we are still. And so with knowing that, I love the fact that Dr. Mo says, I talk to all of my patients, and like she suggested, maybe it's with dealing with everything else that they're talking about. I know that when I've asked fellow colleagues, what is your hesitancy with discussing lymphedema? And again, we're not talking about going through a whole lengthy discussion when you are initially meeting with that patient, but at least mentioning it because they are aware of it now. Back in the day, back when I was first diagnosed, maybe not so much. Things have changed over this last decade. And the fear of getting lymphedema after your cancer treatment is alive and it is real and it is palpable. And so when I ask, why don't you have these conversations? Many have replied, I just felt like I was already overloading them. I've given them the big C, and now I'm telling them something else. And so what I have been attempting to do is to educate, okay, the first time you see them won't be your last. And it probably won't be the last time you see them even prior to surgery. Somewhere between that time, not mentioning it is not going to decrease their risk. Not mentioning it is not going to help them better prepare for something that could happen. So mention it. Mention it and mention it though with, I like the way Dr. Mo says, I refer everyone to my LPP, my lymphedema prevention program. So mention it in the sense that, hey, this is a risk. However, there are options for you to help reduce the risk. So you're not just throwing something on their plate. You didn't just tell them about cancer and failed to tell them about treatment options. You didn't tell them about cancer and failed to give them points on things that you could do to help decrease your recurrence. You've been doing a whole bunch of drinking alcohol. You better bring that down, baby, because we know that there is an association. So just like you give a diagnosis and you're able to give additional things that you could do to reduce your risk or treatment, consider it the same way with lymphedema. And now there are, like Dr. Mo said, at her LPP, you do the measurements around the wrist, the arm to detect it, but tape measure does have a lot of subjectivity that is a part of it. We do the best we can. We measure, but maybe we don't pull as tight, or sometimes we pull too tight, when we're crossing. There is now technology that studies have shown there is an opportunity to not use tape measure, but actually have a valid, reliable way to test and for the detection of subclinical lymphedema. Subclinical, here's the importance. Like Dr. Mo gave the accurate, best layperson's description of lymphedema I have heard to date. Thank you for that. Spiderweb, stealing it.
Yep.
But the lymphedema develops in stages 0 to 3. By the time most patients detect it, it is stage 2. And it is irreversible at that point. And it becomes a chronic condition that someone will have to manage for the rest of his or her life. But a large proportion of patients and even some physicians are not aware that chronic lymphedema that I'm living with is preventable, but is only preventable when you can catch it in its subclinical stages 0 and 1. And there is a SOZO device. It sounds very technical, but it really is just like a tall scale. You step on it, bare hands, bare feet. You don't feel a thing. It's just like stepping on a scale at home. 30 seconds, it reads your, what we call LDEX score. This score is merely just measuring the fluid levels in your body, just making it very plain and simple. But monitoring a baseline level, say before you've had surgery, before you've had chemo, before you have radiation, depending upon, how your physician decides is the best way to treat your particular cancer, having a baseline before treatment is done, and then monitoring that patient every 3 months for the initial first 2 to 3 years allows the clinician to be able to measure this LDEX score. And when there is a change, ding, ding, okay, alarm goes up. And when we reach a 6.5, we're looking at a certain deviation. When it gets close to that range, now we've been able to determine that with simple at-home care, wearing compression garments, 12 hours a day for 4 weeks, now resets, if you will, that spider web. And now we're able to prevent the chronic debilitating lymphedema. And I think a lot of times some physicians had gotten a little about the word prevent. It's like, how can you prevent lymphedema? I mean, just lymphedema occurs. So let me clarify. I'm talking about preventing the chronic debilitating lymphedema, because the lymphedema was detected in its subclinical stages when you still could do something about it. It's like catching a pre-diabetic patient. You can get them in and do some modifications with the diet, do some modification with exercise. And now they never see the actual diagnosis, but you got to get in when the getting is good. Yeah.
So Robbie, what did you know? Did you know anything about lymphedema before your surgery? Did physical therapists talk to you and measure you and that sort of thing? And what did they tell you?
No, because I was diagnosed in 2008. I don't know if doctors, did not have this information at that time, but she did tell me, there was something called lymphedema. She did give me some ways that I could avoid having lymphedema, such as not getting your blood pressure taken on that side. Don't get any, shots or sticks or anything like that in your arm. Don't lift things that are too heavy. Things like that she did tell me.
But that was after your surgery. Was that after your surgery they told you that?
This was before my surgery.
Okay, it was, okay.
When she was going over all the different, all my treatments for the cancer, she did mention that there's something that could occur. So she did, make me aware of it, because I had never heard anything about it before that. But I was not, I think, prepared for, as you said, wearing the garment all the time, people looking at you strangely when the garment is a different color. Like I used to wear one that was brown like my skin, but it was really, really dark. So it wasn't my actual color. So people would look at me funny, or if I had my hand garment on, it just made you feel a certain kind of way. So I wasn't really prepared for that, but she did, give me some kind of idea of what could happen. And I had 3 lymph nodes taken out, and out of those 3, 1 was cancerous. So really I had a very low chance of getting lymphedema, but I still, after a year is when I developed it. Yeah, it took about a year.
And so they didn't go back and take more lymph nodes from under your arm, just those 3?
No, just those 3.
Right.
And then once it occurred, then she sent me to the therapist, and then I went through the whole, all the therapy weeks and weeks of the drainage and the wrapping and then getting fitted for my garments and all that.
Yeah.
See, this is, I think the audience can appreciate how there are 3 different stories.
Mhm.
One had 3, remove 1 positive. One had 10, remove 7 positive. I had 16, remove 3 positive. The one that had 10, 7 positive doesn't have lymphedema. The
Right.
one that had 3 with only 1 positive does. Me with 16 and 3 do. So it is to have an objective measure, because as you can see, I mean, if the 3 of us would have had the opportunity to have this type of technology, it is interesting to see, you know, what would have happened with you and I, Robbie.
Yes.
And you know, Ricky would have went on and been as beautiful and fabulous as Ricky is now. I'm doing her long. But you and I could have
Right.
had a different story. And so this objective new technology is extremely important. And as far as I'm concerned, is a game changer.
Definitely.
Yeah.
Absolutely.
We got to talk about risk factors for lymphedema, because there are risk factors. And so there are some people that are maybe more prone to it than others that we can, again, you know, put on our radar. And while this is a conversation that should be happening among everybody, I think that, you know, doctors, if there's a need to look at who's at highest risk, okay, there are some risk factors. People who are smokers, people who are diabetics, people who have completed chemotherapy, because the chemotherapy shrinks those little lymphatics, those little spider webs get shrunken down even more. And so the potential for backup in that system is even higher. People who are what we call morbidly obese, and that is a huge question and issue within our communities, you know, of what is BMI and whether or not obesity is truly obesity in the Black community. Because when you think about our bone density and things that contribute to that, you know, the ideal body weight is not so ideal after all. But there's some risk factors for lymphedema, you know, that we need to put on our radar, because, you know, patients who have that should be spoken to and educated extensively about it. And you know, you're right, Dr. Sherry, before when we didn't do sentinel lymph node biopsies, meaning finding that first lymph node that the breast drains to, we would take out one lymph node and send it for frozen and take out all the lymph nodes. And we did what's called axillary lymph node dissections. The risk of lymphedema from removing all the lymph nodes up to 25% is huge.
Huge.
And so there's a whole group of women who are walking around who had cancer in the 80s and 90s and early 2000s and weren't counseled about lymphedema at all and never even heard of the word, because they had all their lymph nodes removed before we would even just pick out the 1 or 2. And so we got to go back even and educate these women, because they've been grappling with this for a long time. And I wonder if you can talk about some of the long-term side effects of chronic lymphedema. What have you experienced and what have you seen?
And how about pain? Pain.
Pain is real. It's especially at nighttime. I notice when I'm still and I'm lying down, it's like a throbbing pain. My doctor says it's normal and it happens, but the pain, something I wasn't aware of, cellulitis. I had never heard of that. I ended up in the hospital because I had cellulitis. I didn't even know what it was. My arm just started throbbing. It got really red. It got splotchy. I couldn't put the garment on because it wouldn't fit. So I called my doctor. She gave me oral antibiotics. They didn't work. So then I was hospitalized for 3 days. I had to have a drip with antibiotics to get rid of it. Well, it's caused because of bacteria, something getting in from my skin. It could be a little teeny cut, a little scratch, anything on that arm. So, you know, all I could think of was that I went swimming and maybe something was open when I went swimming. So I wasn't prepared for those kind of things. Yeah.
I agree, Robbie. And I have not experienced infection like cellulitis, but what I have experienced, definitely the pain. Symptoms are definitely worse at night. I have what feels like there's a medical condition called Raynaud's syndrome. And I can tell you, when my fingers get really cold, if I stay outside in the cold, like this past major storm we had in February, and I was out there trying to dig my car out, my fingers went purple, then bright red, white, before they finally start calming down. And so I have to be very careful about my exposure to cold. I have to be very careful about my exposure to humidity. I find that when it is humid and hot, that makes it worse. It always, most of the time, it feels like like something is going to, like, it feels like it needs to pop. Like it's
Yes.
like my skin is just stretched. Sometimes I feel very used to it, and maybe I'll have a couple of days where the swelling goes down, but when it starts to creep back up, then you know it's not going to pop, but it's just a strange, very uncomfortable feeling. And
is.
certainly cellulitis is a risk. Had your cellulitis not been treated, that can turn into sepsis. So this is no joke. It is not just some swelling. And you know, the social, psychosocial aspect of it, that embarrassment part of it. When I was diagnosed, I was still single at the time, and I was concerned about if I would to ever get into another relationship again. I wear an oven mitt at night. That's the best way to describe it. It's an oven mitt that comes way up here, and it comes with, that's it. Mine is black. That's it. That's it right there. The oven mitt. And so, you know, I mean, my husband and I, we moved past it, but initially at first it was like, okay, so I'd hold up the oven mitt and it's like, tonight, like now, because I'm about to put this on. And once it's on, it's really gonna get in the way. So you know, things like that we as physicians, if you're not exposed to it and you don't have it, you're not thinking about it. But we literally have had one disease, breast cancer. When you read the literature, we're beyond that 5 years. Some would even consider us cured, but we had one disease to cause another that cannot be cured. There is no cure for it. And so therefore, having opportunities like this to discuss lymphedema, to really get into the nitty gritty about what we go through and what we live through, to be able to potentially have an impact where we can save thousands and not tens of thousands, hundreds of thousands of individuals, to not have to live through this, then you know what, me going through this will be a blessing for others. But
Absolutely.
I definitely don't want to have me just living with this to be my only legacy, that I lived through it. I want to be able to live through it and to help others not have to.
Absolutely.
This falls under that category of what we call survivorship, right? So it's not just what happens during surgery, radiation, and chemo, but it's everything else that impacts the entire quality of your life thereafter, that we really need to pay more attention to as physicians. You know, surgeons are but one part of it, but they're the gatekeepers to all of this understanding for patients, right? So the eyes can't see what the mind doesn't know, and if we don't introduce this to patients and talk about these things, they're going to move forward to the next doctor. They're going to move forward to the next one. They're going to move forward and think, oh, well, I guess this is how things, you know, this is how it's supposed to be now. I guess this is what it's like from now on. And you know, notwithstanding issues of things like neuropathy from chemotherapy, right, which can also confound lymphedema, the importance of having an empiric measurement through LDEX is something that's, I think, increasingly important, because as patients go through chemo, they can get numbness and tingling. You know, people have neck issues, they can impinge a nerve, they can have lots of things that create similar feelings as what lymphedema could feel like, some of that pressure that they're having. But let's talk about the LDEX and the SOZO machine and the way that works, because the concept is called bioimpedance. It's looking at the flow of electricity or current through the water in the tissues, right? So you can stick your hand in a pitcher of water and see how the water's displaced, and you could sort of measure, and that was like the cheap measurement of bioimpedance back in the day. And sometimes they used to measure lymphedema that way and see how much water gets displaced. But this actually shoots a little electrode, like a TENS unit, through the body. It shoots a little current to see where the current is impeded by the water flow or the backup in the tissues. And so it is really a much better measurement than just one, sticking your finger in water, or two, just doing, you know, routine measurements around the wrist and the arm, because who says you do it at the same point every time even?
Right.
Correct.
And
Or
when do you
even
do
that the
that?
same person is doing it.
Right. And when do you do that? Like, so you've had your surgery, at what point do you start to think about this and worry about, like, when should you address it?
Good
Before surgery,
question.
ideally.
Say it again.
Ideally before surgery, you know? Yep, before surgery, you want to get a baseline measurement. You want to get a baseline tape measurement. You want to talk about those symptoms. You want to look at the patient's arms. You want to look at where their body fat is. You want to be able to identify what those risk factors are and counsel about those, and then do that measurement before surgery and then after surgery. So usually several months after surgery, about 3 months or so after surgery, and every 3 months, I think, Dr. Sherry, is about the recommendation right now from the Lymphedema Society, you know?
It is. It is. And the beautiful thing about with the Sozo device, and I'm grateful for the technology, because doctors like you, Dr. Mo, did the right thing by their patients by getting a baseline and having a lymphedema prevention program where they were monitored on a regular basis. I know that those patients fared much better than institutions or physicians who chose not to have a lymphedema prevention program, who merely relayed that this is a risk factor, and then when the symptoms developed, sent them to, physical therapists, Lana trained in how to deal with lymphedema, doing the proper manual lymphatic drainage and the taping and what have you. And at least that patient, once they developed lymphedema, they got the care that he or she needed. But the beauty with this bioimpedance is that when an individual, and it depends on the institution, right? So I would say with you, Dr. Mo, because of the rapport that you have with your patients, if you were to ever have a Sozo device, I would want it to be in your office, right? Because you've taken ownership of having the conversation. So therefore it starts with you. The patient will have their baseline testing done, have surgery. He or she may have even gotten started on chemotherapy even before it's time for their next time to get tested on the Sozo device, because you're measuring it every 3 months. And so by doing so objectively, now you've prepared your patients, you've given them the risk factors, you've kind of explained what lymphedema is. Your lymphedema prevention program has now placed them into a monitoring pattern so that they're having this frequent follow-up, whether or not, if you don't have a Sozo device, you're doing tape measure. You do have a Sozo device, yay, 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 you're doing it objectively. The patient stands on it 30 seconds, don't feel anything. The clinician can now make the proper determination as to whether or not this patient we need to have intervention now, because without that intervention, they're now going to be facing stage 2 of lymphedema, right? And so determining who is best to have that conversation is key with patients. And I think for any facility that says we are a cancer treating institution, right? We are a cancer center. We want to be known for treating our patients with the best possible care and having the best possible survivorship in mind. That type of institution needs to sit down and determine, okay, when it comes to lymphedema, we do need a lymphedema prevention program, or we have one. If we have one, how can we improve it? If we don't have one, after listening to this, you need to have one, because you're doing your patients a disservice. I know that as physicians, we think about what the patient may have now when we want to get them treated. The main thing is get the cancer out of them. We want them to live, and we want the cancer out of them. But you and I know that there is life on the other side of cancer. And we as physicians, with our altruistic selves, want them to live the best life possible. And so with that in mind, how can I take my program a step higher to give my patients what they need? And by doing so, the community is best served. And I can assure you, those patients will continue to come to your institution. Those patients will have their family members come to your institution. And now really you as a hospital within the community will be serving the community in the way that the community needs to be served.
And deserves.
Yes,
But
ma'am.
guys, what if so now if you're doing immunotherapy, and now even a lot of the therapy for triple negative is to do chemo first.
Mhm.
So you do a course of chemo before you have surgery. So should you be measured before the chemo starts?
Yes, you should.
Absolutely.
Absolutely.
Absolutely should, because chemotherapy affects the lymphatics. It affects that lymphatic flow. This is how tumors then can shrink, and it's how we can change the stage of breast cancer. We can downstage it a lot of times, where cancer used to be in those lymph nodes after chemotherapy. We can go back and find those lymph nodes, and sometimes you can't trace it. We do what's called lymphoscintigraphy, or a dye that goes through that spider web system right before surgery. You know how everybody, you got to go get that dye the day before or the morning before surgery. They give it right above the nipple, and it kind of stings and burns a little bit, and they'll tell you that either. But that dye travels
Like a Dickens.
that I give a little Emla cream, like a pain cream for it, but that dye travels underneath the skin through the lymphatics, and after chemo, those lymphatics can shrink down. And so it's important to measure even before chemotherapy. And I think that's another area, Ricky, where we can really improve. And Dr. Cherie, that's a study that we might need to look at, the percentage of doctors who are sending patients for lymphedema prevention before chemotherapy, and what their impedance looks like after chemotherapy. Right? Has it changed any?
Check it out. I would have been so mad. I would have been so mad. Like, there's so many things I get mad about. And it's usually because we're not told something, but I would have been furious to know that I could have done something about it, and I wasn't told.
You
And
didn't have the option.
so many times with so many pieces of our cancer, and it's because we're Black women. Like, here I go again with my, the Black thing, but it's just scary that that this is out there and can be addressed.
Correct.
Before you have to deal with it. And so it's really important education.
Yeah. There are other ways to diagnose lymphedema, that can include dye injections and, again, lymphatic mapping. But those ways are still somewhat experimental and kind of clumsy. And we can even trace the other lymphatics to try to prevent. I know someone in the comments mentioned reverse mapping. It's still fairly experimental in clinical trials, but we can inject down in the arm and someplace else to see which lymphatics and which lymph nodes go to the arm to try to prevent lymphedema. So there's a lot of new stuff on the horizon, but in terms of actually treating lymphedema, Dr. Cherie, you want to comment a little bit on ways to treat lymphedema once it happens?
Sure. Well, once it happens, typically the mainstays of treatment are manual lymphatic drainage. You may experience when you initially go into your therapist that they're doing not only manual lymphatic drainage, but you may get taping, wrapping. These are various different ways to not only provide compression, but it's also a way to, if you will, not trick, but to recreate or remind your body the flow of the lymphatic drainage. And if you have a blockage, then you need to open up other areas so that we can get the fluid out of the arm, but then now we can have it drain more so towards the chest and towards the pelvis, because we know that
go back a second to the word drainage. That sounds like it hurts. That sounds like you're
no. Actually, the manual lymphatic drainage feels good.
It helps. It feels better.
It feels better.
Massage.
It's
massage.
a nice
Massage.
It sounds like you're going to cut something and it's going to drip out.
No. I'm so glad you clarified that.
Yeah.
No, actually, this is a very light massage, and it's not even
Very
like
light.
deep massage that you think when you go in to get a sports massage or massage envy.
Okay.
This is very light touch. Your lymphatic system, they're not very far up under the skin layer. So you really want to do it just a soft manual lymphatic drainage. But what it is important is that if I know I have blockage here, I can do manual lymphatic drainage in a direction that is pushing the fluid back here. Well, the fluid is not going to go anywhere because I know that area is blocked. So now I have to learn how to do massage just that I'm redirecting the flow into other areas that are open with my lymphatic drainage. And your therapist teaches you all of this. But this is also part of the therapy and the treatment. Once you now get to a place where you now have gone through seeing your therapist, you are now at your baseline. You're not seeing any further improvement with the swelling on a consistent basis. You're then placed into compression garments. And there are various different sizes. They're various different compressive strengths. You get into your compression garment. And then you continue your manual lymphatic drainage. I typically perform mine in the morning. I'll do another drainage in the evening. Some individuals have been placed on pumps to help them. Mine was not conducive to having a pump. So I do my drainage once in the morning, once at night, wear my compression garment. And then, yes, I'm very conscious about making sure I don't get the cuts. You know, it's clearly I'm getting nails done, but you know, when you clip in around the cuticle and stuff, don't fool with me on that. So I'm very cautious about this extremity. I need to be, I have to be.
Yes, it actually happened to me the other day. I cut my finger cooking and it's on this arm. So of course, you know, my fear and my anxiety is really high because I want to make sure I don't get any bacteria. I don't want to get an infection. You just have to be really cautious.
Careful.
Yeah.
So how do people get information about this? I mean, you know, clearly they can call you guys and we appreciate that, but like, should we put something on our website about what questions to ask? Like, how can we get people, help them get informed?
Well, one, you can definitely send them out to the Live Today website. I have information out there about
Great.
lymphedema prevention programs. I have patient education
Great.
resources, tons, how it's diagnosed, treatment. So if they go out to live-today.org, start there. Is
Okay.
even further information
That-
about the Sozo device. They
Right.
can start there. And then I have resources that connect them to other sites that will give additional information. Because again, I'm not a nonprofit that feels like I want to just hold on to it. Anytime other outside institutions send me valuable information that I feel patients will benefit from, I go ahead and I make an opportunity to create that and place it on my website so that they can go and get the help that they need. If it starts with me, but it ends with touch, beautiful.
That's right.
Well,
I
yeah,
know
and you guys, I have sent so many people to Dr. Cherie. You know, she's helped them. And you know, Allison, you've helped so much.
Yes,
So
yes,
I appreciate, you know, everything you do,
absolutely.
because I will say, here's who you call, but you know, we have to, you know, make it more widespread and it's got to be early in the treatment cycle. I mean, it's got to be
Exactly.
in the diagnosis part of our treatment cycle. So
That's right.
You know, Ricky, other places people can go, the lymphedema, the National Lymphedema Network, the lymphaticnetwork.org. There's some other educational websites. And do advocate for yourself in terms of talking to your doctors about therapy, about lymphatic massage, about prevention, and hold them accountable for it. Don't have them just assume that because you got a new cancer diagnosis, you're so overwhelmed or you finished your chemo and you're focused on surgery, but talk to me about what to expect. What are my risk factors? These are questions that patients can ask. And once you've had a chance to digest that diagnosis, it's a good thing to circle back and ask your doctors about it as well, and hold them accountable for teaching and educating patients on this. And, you know, if they didn't, it's a good thing, you know, and it doesn't feel good to hear it, but it's a good thing to talk about and say, you know, doc, I wish I had known more about this. Do you think in the future, you know, that you could tell patients more about this? Or can I talk to patients about this? Can I be an advocate about this topic? And so you get educated, and next thing you know, you're a patient advocate and you're helping other people through it as well. So you can turn that test into a testimony for sure.
yeah,
And
we know
you beat me
that's how
to
we
it.
roll. We know that's how we roll as breasties. You know, we got to help each other out.
Absolutely.
Yeah.
Yeah, Dr. Mo beat me to that. And one of the main reasons why we have opportunities like this is because we as physicians, to have the expectations that patients will come to our office and just say, okay, doctor, yes, doctor. For the most part, those days are gone because the internet has
Dr.
opened up.
Google.
So,
Yeah,
right,
Dr.
so we as physicians, one, need to be educated so we can nip the myths that they may read out there. And they have so much information coming from so many different sources that we as physicians, one, need to help them understand what's real, what's not, where you should go for valuable information, and what it just may be hearsay and a bunch of people just giving their opinions. But we as physicians also need to appreciate that patients are going to come to us and they're going to ask for particular treatments, particular tests, specific treatment plans. We need to be able to speak to it and answer to it. And I want every cancer patient out there, every patient that even has never been diagnosed with cancer, you now know the word lymphedema. if you, a family member, a coworker, a neighbor, says something to you, I've just been diagnosed with cancer, you give them some support, and then you find the right time, not too far in the distant future. Has your doctor said anything to you about lymphedema or the risk of lymphedema? Please do them that favor. And if you become the patient, when you get into that doctor's office, you listen to what the doctor says, he or she has to say. If you never hear the word lymphedema, you bring it up. And if they bring it up and say, yes, 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 I was getting to that. We do have a lymphedema prevention program. Next question to ask them, do you have a SOZO device? Well, no, we
Right.
don't have a SOZO device. Then how do you measure my risk of lymphedema from now moving forward? What is your lymphedema prevention program look like, and what is your plan, so that you two work together and you understand the risk as time progresses? Because I'm telling you, I am so grateful. 13 years, Robbie, we
Me
are
too.
just 2 months apart, right?
Yes,
This
yes.
is a beautiful time. It's beautiful. But I can't even describe to you how
Yes.
I would feel if I didn't have this, because I've
Right.
been living with it for 12 years.
Me too. I agree.
And the oven mitt, and the oven mitt.
And,
The
and
other- Hers is
That's how-
purple though. I should have got purple.
that's how I describe it to everyone. That's perfect description. The oven mitt.
Wow. Wow, wow,
Oh,
wow.
this has been incredible. Oh my goodness.
You
Yeah.
guys are so awesome. You guys are so awesome. I'm sorry we
Yes.
have to end a little early today, but we so appreciate you. I put your website in the comments, and we'll
Yes.
do a post about it, and
Please.
we'll do a blurb about it. Let's work together and do an e-blast about it, Dr. Sher.
Definitely. And if
Okay.
you can go ahead and put ImpediMed's name, put impedimed.com out there too.
Okay.
Because they have some additional information about lymphedema, where to go for resources,
Okay. I'm
where
gonna
to
put that-
go. Yeah,
Yeah, I'll put that
absolutely.
here
I
too.
didn't do, obviously I wouldn't duplicate what they had already done, but they have some very good patient educational resources there.
Right.
Webinars that they can listen to, just all types of things that we obviously didn't get to, but definitely put impedimed.com in there as well.
Great. Wow. This is so helpful for everybody.
I
So-
can't wait to work with Dr. Mo.
Oh, I'm so excited. Listen, we have much work to do. And so
Much
work
we're
to
going to
do.
start looking at some trials and figure out how to get
Yes.
that data. And,
Yes.
you know, this is what Ricky and Touch, this is what we set out to do when we
Our
designed
purpose.
it, was that we would look at clinical trials and research, especially affecting our community, and get some answers and get some data for us. So, you know, Ricky, this is another area that we can
Here we
definitely
go. Yeah.
partner with. Let's go, because you know the data surrounding Black women and lymphedema, it's there, but it's old, and there's a lot of patients that need a lot of relief. You
Yes.
know, they weren't told about it previously. They've had their lymph nodes removed, and we need to educate our community and get us some answers and some relief, and start looking at some treatments that work for us too for
Or-
lymphedema.
Yeah. And it's prevention and relief for once you got it. But
Yes,
prevention is, how many things can we prevent with breast cancer? Not too many. This one
exactly.
we can control. Let's make it happen.
There you go.
Absolutely.
Yeah, Robbie,
you
thank you for joining us and being part
Thank
of our
you, Rob.
family here.
Oh, thank you, ladies. It was
That's my
wonderful.
fellow
I'm so
family.
excited about all the new technology. It's awesome.
Wonderful.
Thank you.
We got to have you back again, and Dr. Cherie as well. We got to have you back again and again and again. Telling
Definitely.
stories, so many different facets. Every time we hear your story, Robbie, you too, every time you tell your story, it's gonna be something different for people to learn about your journey through breast cancer. And so we're really thankful.
Yeah. Thankful.
Definitely.
for the
Thank
work.
you for this platform.
All
Thank
right.
Thank you,
for the
Ricky.
vision. God bless you guys.
Bless you guys. Breasty love.
Breasty love.
We hope it's been relatable, reliable, and real. That's what we set out to do every Wednesday, the doctors and
Great. Doc, next week we're going to talk about breast cancer and Alzheimer's.
oh yeah.
So if you know
Wow.
anybody who's dealing with Alzheimer's and breast cancer and
Mhm.
dementia, all those things, we're going to talk
Yes.
about
We're
Definitely.
looking for those stories. The way that we treat our elder patients and our patients who have things like Alzheimer's disease is changing. And so we're going to definitely talk about, you know, what's new, what's changing, and how to navigate those things for
Yeah.
sure.
that.
Oh my goodness, definitely. I have someone for you. Yes,
Great,
yes,
great.
yes,
I'll call you. I'll call you tomorrow.
definitely.
All right. Blessings. Thank you.
Bless.
Thank you.
Bye, Breasty love.
Bye.
Bye.